Well, welcome everybody. Thank you very much for joining this session on health data science at pace, where we're going to hear about how discovery has been accelerated during the course of the COVID-19 pandemic. My name's Cathy Sudlow. I am director of the British Heart Foundation Data Science Centre within Health Data Research UK. We've got 4 fantastic panelists lined up to each give a short talk. So we're going to run those back to back. I'll introduce each of the panelists in turn, and then at the end, hopefully we'll have time for a really good and robust discussion. So do use the question system to lodge your questions as they occur to you as you're listening to the panelists, and we'll try and cover as many of those as we can during the course of the discussion. So without further ado, I'm going to introduce our first panelist. Most of you will have come across him because he's been very much in the media over the last few months. So we're delighted to have with us Martin Landray, who's Sir Martin Landray, who's Professor of Medicine and Epidemiology at the University of Oxford, and importantly, lead investigator along with Peter Horby of the Recovery trial, which is a great exemplar of a data-enabled clinical trial. Martin, over to you.
Thanks very much. And if I can have my first slide. That's great, and now we can move on. That's lovely. Perfect. So really this has been my hypothesis and work for some time, and has been core to HDR UK, but really that we need to reinvent randomized trials as a fundamental feature of how we work out which treatments or indeed which health interventions work and which ones do not. And there are different elements to this, of which data is one. And of course, in today's context, we'll talk a lot about data, but I want to sort of highlight that that is only one part of the overall picture. We need smart design and delivery. It needs to be integrated, yes, with the data, but also with the healthcare system. It needs to be supported by proportionate trial regulations and guidance. And we really have to have a fairly substantial rethink about some of that. And that the objective, and I think actually what is, as I'll show you, can be achieved, is a huge benefit for individual patients and for public health. We have the next slide. If we go back a year, of course, we were facing a major public health crisis, but perhaps just to put it into some numbers, for patients admitted to hospital a year ago, then 1 in 4 of those patients sadly would not survive that hospital admission, and the picture was even worse for those who had more severe disease. We had no treatments, a huge number of candidate drugs, many opinions, no reliable data. And of course, you know, many of those opinions were coming from expert scientists, but they were also coming from lay audiences in the media and from high profile political sources. You can name, I'm sure, at least 3 miracle cures to emanate from one platform in America, and we can touch on some of that in due course. But we really needed randomized trials to actually work out which of these candidate treatments would work. So next slide, please. In the context of a pandemic, and actually I would suggest in the context of all of, one before please. In the context of a pandemic, and I'd suggest in the context of all of our busy lives, whether you are working in the NHS or using the NHS, the trick is to keep things simple so that they're doable. Simple eligibility, patients hospitalized with COVID, what happens to them? Can we reduce the risk of dying, the need for a ventilator, the duration of hospital stay? Absolutely needs randomization. Just dredging through data is not good enough. It can produce seriously misleading conclusions. So everything that I talk about is founded on the principle of the coin toss. A 1-page case report form at the beginning, another 1-page case report form at the end of 28 days, and extensive linkage through to NHS data, particularly through NHS Digitrials and similar organisations across the country. Next slide. So here are those data sets, and this has been a sort of phenomenal record linkage and data utilization program. Rather than burdening frontline medical staff with collecting information that's already in the health system, why don't we just go direct to that health system and use those data? Unfortunately, we might have one NHS and one NHS logo, but we have many, many different organizations and many, many different places in which the data is located. One could argue about the logic of that and the rationale for that, but it does seem to me that if we've got one NHS and one NHS logo, it would be sensible to have, broadly speaking, one approach to accessing NHS data. Hospitalization data, mortality data, primary care data, data on COVID testing, data on the use of ventilators and intensive care. Overall, 25 different data sets. Next slide. And COVID can affect anyone. And so we made sure that the trial was open to everyone. You can probably, some of the dots are small because some of the centers didn't recruit enormous numbers of patients because they didn't have an enormous number of patients. Others are very large. But from the Western Isles of Scotland down to the G7 county of Cornwall, right the way across from Northern Ireland to East Anglia. Over 40,000 patients have now been enrolled. Within 9 days of writing the first protocol, we were up and running. Within 100 days of that, we had the first results. And of course, we had a huge surge this past winter. The speed of recruitment was phenomenal. At its peak, 1,000 patients enrolled in the trial in 30 hours. Next slide, please. So let's talk about the results. And I realize that some people are more or less familiar with some of these sorts of formats, but essentially this is days in hospital, or days since you were randomized, days in hospital, think of it along the bottom line, and upwards is the risk of, or the proportion that have died. And what you can see is that for these 4 treatments, I've given you 4 examples that were widely recommended, very loudly promoted, widely used. None of them have any benefit for patients who are admitted to hospital. So hydroxychloroquine may have been proclaimed as a miracle drug. It turns out it's useless in this setting. HIV treatments, antibiotic treatments are better used for HIV and for bacterial infections. And convalescent plasma, which was given to 500,000 Americans because it was too hard to do a clinical trial, their phrase, not mine, actually it turns out it's useless for hospitalized patients. Next slide, please. But also some wins, and bizarrely, last year's HGR UK annual symposium was on, I think, the 16th of June, and it was about 1 hour before these results went public. It was hard giving that talk, I can tell you, but what this showed was that this cheap, widely available steroid drug reduces mortality by 1/3 in the sickest patients on ventilators, by 1/5 in other patients. That was announced at lunchtime on the 16th of June. It was NHS policy by tea time. It was policy across the world within the following days and weeks. And if you click on the next slide, it's estimated that the treatment has saved, in some people's estimates, over 1 million lives. It's certainly over 500,000 lives. That's a lot of lives saved from a simple intervention, but we would simply not have known that without a simple trial and without the data. Other treatments that we went on to identify in early this year, a drug that's normally used for rheumatoid arthritis also dampens the immune system, provides additional reductions in mortality, even on top of that steroid drug. And then just last week, again on the 16th of June, but 2021, next slide, the discovery that for patients who don't make their own antibodies for whatever reason, they're often elderly or frail, or perhaps have got other medical conditions, patients who don't make their own antibodies against the virus, giving them antibodies in the form of an antibody cocktail improves survival, again on top of the steroids. So each time we're chipping away at the problem and have made altogether a pretty substantial dent in the terrible mortality for hospitalized patients that we started out with. We would not know any of this if it wasn't for randomized trials, and we probably would not have got here any time like now if it wasn't for the use of the data to inform those randomized trials. Next slide, please. And so I want to finish with some sort of conclusions on not just about recovery, but about the future of how we work out which treatments are useful and which ones are not. The first thing I'd say is that trials actually are an essential component of high quality clinical care. They're not some risky add-on that goes on the side. Actually, they're fundamental to knowing whether treatments work or not. In my field of cardiology, probably the best field for evidence-based medicine, 15% of all our recommendations and guidelines are based on sound evidence from clinical trials. That, I think, is something which we have to improve, and we have to improve it across the piece, not just in cardiology. But arbitrary use of unproven treatments is damaging to patient care, wastes resources, and is a false and unjustified promise to patients at their time of need. And compelling results absolutely change practice. But for that to happen, we need trials to be designed well. We need to be feasible for both patients and staff. They need to be inclusive and focused on outcomes that matter. And health data can broaden participation, every hospital in the country, increase the quality, clear results, and increase the relevance of those results directly applicable within hours back to the NHS. Those lessons are not only for COVID, but they are for the burden of many other common diseases that affect both individual patients, public health, and the place burden on the NHS. My final slide, please, is to say thank you. I've used a lot of numbers, I've used a lot of talk about data, but everything is about individuals. I'd like to say particular thanks to the first set of individuals, which is the doctors and nurses and healthcare staff and research staff at nearly 180 NHS hospitals. Over 4,000 people have contributed to this one study. But most importantly, I'd like to say thank you to the over 40,000 people who have participated in this extraordinary project. In extreme circumstances, when we talk about data, we talk about numbers, we talk about COVID, we're used to the ticker tape of numbers that appear on the front of our newspaper and on the front of our websites and news reports. Let's remember that each and every one of those numbers reflects a real person, a real family, and very sadly, too often real tragedy. So the reason we do these trials, the reason we use the data to inform these trials and deliver them better, is so that we can improve outcomes for tomorrow as a consequence. Thank you very much.
Martin, wonderful. Thank you very much for sharing your insights there with us. And please do enter your questions for Martin whilst we move on quickly to our next panelist. So I'm delighted to welcome Professor Liz Sapey, who's the director of the Pioneer Health Data Research Hub for Acute Care. And she's going to talk to us about using real-world data to improve care pathways for COVID-19. Liz.
Thank you, and thank you for this opportunity to speak. Could you put my slides up, please? So as well as being the director of Pioneer, I'm also a frontline clinician. So I was one of those people that was utterly terrified knowing what was coming from Europe and really having no information how to treat it. Next slide, please. And although Pioneer was only awarded funding in November 19, and therefore had only been running for sort of 2 months before the pandemic struck, we knew that we had to immediately refocus to try and help address this critical challenge. Next slide, please. So Pioneer is the hub in acute care, and acute care is any unplanned healthcare contact. And as you could imagine, COVID pretty much fit the bill very much for this. I know the slides will be available later, so I won't go through this in detail, but this slide really outlines the critical challenges of acute care, which is a major burden to the NHS year on year. Next slide, please. So as a consultant working in the front line and also joined by fellow doctors and nurses and allied healthcare professionals that had perhaps never worked in frontline medicine or had not certainly been in the emergency department of a hospital for many years, we knew it was important to structure the information that we were capturing on our COVID patients, not only so that we could help our clinicians provide care for patients, but also so that we could capture information really from patient number one coming through a hospital. So Pioneer built with UHB Hospital a COVID clerking sheet that was embedded across 4 hospitals in Birmingham to start capturing that data. And this gives you a snapshot of the kind of information that we were collecting, very much based on clinical trial data and observational studies that were coming out from across the world. But also you'll notice with a panel of advice for clinicians in terms of how you might rate the severity of COVID, because for all of us, it was the first time that we'd seen patients with this condition before. Next slide, please. Working with colleagues in the University of Birmingham, we were able to rapidly set up testing for all of our patients through the door. And that meant that we could use our electronic health system to annotate which patients were suspected, then which ones became positive, and we could track them through the hospital with a B symbol that you can see on the slide. We also knew from observational studies that there was some interest in biomarkers to help work out not only the severity of COVID, but the complications that patients might experience. So we set up blood bundles, which meant that rather than relying on the individual clinician to remember to tick an individual box for bloods, as soon as they registered that a patient might have COVID, the biomarkers of interest were automatically requested by the hospitals using our electronic systems, meaning that we were generating data in real time in great numbers, because Birmingham was obviously hit very hard in wave 1 and the subsequent waves of COVID, but in a structured and unified way. Next slide, please. And working with colleagues in HDR UK, the University of Birmingham, and our own health informatics department, we were able to look at that data in real time as it came through the door. There were some signals that we were picking up. The first is that patients with COVID often had very wet lungs with ARDS. And that meant that there was a tendency for some clinicians to try and restrict fluids for them, which could send them into acute kidney failure. So we were able to see this pattern emerging and then issue advice in simple infographics. And you can see one looking at AKI, acute kidney injury, and the other one is about diabetes, because we could see that patients coming through our front doors were experiencing hugely dysregulated blood glucose, and utilize the data in real time to reflect back how they could be managed to help prevent some of the problems that we were seeing. And these infographics were then changed into different languages and have been shared globally. And I've had lovely images back from hospitals as far as India and Saudi Arabia showing these in use. Next slide, please. We were also able to bring our data together on a twice daily basis to reflect the burden of cases of COVID that we were seeing across the 4 hospitals. So you can see in this that our hospitals have been listed: Good Hope, Heartlands, the Queen Elizabeth and Solihull. You can see that this cumulative summary report started on the 4th of March, so coinciding with our first positive case. And you can see then the waves of patients coming through. We were also able to reflect back to public health where those cases were coming from, enabling us to highlight hotspots of patients before there was community screening. And if we could see, for example, that a particular care home was being affected, we were able to send with patients PPE packets to take home with them back to their care home so that they could be looked after safely and the staff could look after them without potentially as much worry as transmitting COVID to other residents. What you can't see behind this static image is that as a clinician or as a manager with one of these hospitals, you could click on these figures and it would tell you where these patients were and what the staffing levels were behind those wards where patients were being held and looked after, so that we could make sure areas of critical need were matched with staff numbers. Next slide, please. And of course, we could utilize this data to try and understand the risk profiles of patients coming through our front door. From studies from China and Italy, we were able to get some indication of risk, knowing that those of a greater age were more at risk of death. But what those populations couldn't tell us is what that meant for our local population within the UK, which benefits from being incredibly diverse. So we were able to use this data in one of the first studies to highlight the risks of increased mortality in those of South Asian ethnicity. Next slide, please. And we were also able to look at our staff as well. There was considerable concern amongst our healthcare staff in terms of exposure to COVID, in terms of utilizing PPE, which they hadn't used before, and their own risk of catching COVID. So through the COCO study, we were able to look at seroconversion rates in staff across different specialities. And the first graph you can see shows the average seroconversion rate, and then different specialties, and those that maybe had more or less seroconversion than would be expected according to that average. But by mapping when symptoms occurred, we were able to show that most of the exposure occurred before we saw the largest waves coming through the hospital doors, providing some reassurance that our PPE strategy was working and that a lot of exposure was coming in the community. Next slide, please. So this is a whistle-stop tour, and the last slide really brings my summary to this. I think that being based within the NHS allowed rapid action to curate structured data from the first patient as they came through. We were all waiting for recovery to read out and were proud to participate in it and amazed by the speed in which it reported. But we were still looking after the patients on the ground from day one. And we needed some insights as to what thromboprophylaxis to give them, what fluids to give them, what strategy we should use for ventilation. And utilizing our data enabled us to have insights from this, really from the first patient coming through. We could use the data to highlight the emerging clinical problems associated with COVID, which nobody, of course, knew about before. Mapping our patients in real time enabled patient tracking over 4 NHS sites, suspected, positive, and negative, enabling us to streamline our pathways to minimize risk. We could feed back data to Public Health England locally to highlight outbreaks prior to community screening. And we were able to provide some reassurance to staff about protection from their PPE. And I know that tomorrow Susie's going to be talking about prescribing support and some of the other projects that Pioneer supported. So a quick plug for her session there as well. Thank you.
Thanks very much, Liz. A great whistle-stop tour of some of the fantastic work that Pioneer's been supporting over the last year or more. So to our next panelist, I'm delighted to welcome Rosalind Ego, who is Associate Professor of Applied Analytics and a Health Data Research UK Fellow based at the London School of Hygiene and Tropical Medicine. And Ros is going to tell us about modelling for prediction and prevention. Ros, thanks.
Brilliant, thank you. Just while we wait for the slides, I'm going to give a really quick overview of what we've been using models for and what they're useful for. Next slide, please. Thank you. Thanks. So we can use models to understand the fundamentals of transmission, to quantify key unknowns. And some of these are things we've become very familiar with over the course of the epidemic, such as the reproduction number R. And we can also use models to understand how those things change through time. And then importantly, we can feed this forward into using transmission models to understand the potential impact of interventions and responses to those interventions. And from in our work at London School, this has mostly been in response to specific policy questions. Next slide, please. So I mentioned the real-time reproduction number. And since very early in the pandemic, the group at the Centre for Modelling at London School has been producing real-time estimates of the reproduction number, both for the UK and other countries, by ingesting surveillance data, publicly available surveillance data, using cutting-edge methods, and then publicly providing these estimates in real time. And by setting up a really nice, robust, rigorous pipeline early in the epidemic, this has meant that a lot of downstream analyses have been able to rely on these estimates and use them for further analysis, both within the UK and in many other countries. Next slide, please. But I just wanted to highlight that things that these epidemiological parameters that we estimate early on are not constant. And the alpha variant, which emerged in Kent late last year, is an excellent example of this, and some work that we did to try and understand what was going on with that. What you can see here is for 3 areas of England, what proportion of PCR tests had this S gene target failure, which can be used as a proxy for the alpha variant at that time. And you can see it rapidly increased, very rapidly increased through time. Next slide, please. And then we used a transmission model to try and understand what could be the mechanisms for this rapid increase and fitted those to available data. And this allowed us to estimate very, very early on that it was likely that this alpha variant had a higher transmissibility than the previously circulating virus. So it had a higher baseline R. And so you can use models in real time, rigorously fitted to data, to update your information on these fundamentals of transmission. Next slide, please. And I mentioned that a lot of what we then do is to use our epi findings to understand what interventions might do. And so I'm going to show mostly some very early work from the start of the epidemic in response to key questions, one of which was, can contact tracing and isolation of cases control outbreaks? And so here in this case, we use the individual based model, which means we explicitly model each person. And you can see here, person A has a timeline of infection. They get infected after some period, they show symptoms, and then there's onward infection to person B and C. If you manage to trace person B, then you can stop their onward infection. If you don't trace person C, you don't. And what we used this model for was to demonstrate that contact tracing and isolation is extremely challenging for COVID-19. But because there was a lot of uncertainty at this time in that patient timeline, so when do they show symptoms, when do they start being infected, we provided this model in a ready-to-use R package so that other researchers could alter the parameters, could change it to their particular context, and allow both our findings and the methods to be used in other contexts. Next slide, please. We were also asked, can interventions aimed at travelers prevent introduction of cases? So this was actually one of our earliest papers. And at that point, in February 2020, and at that point, the key intervention aimed at travelers was thermal screening in order to determine if someone had a fever. And we asked, we found that thermal screening is not particularly effective at preventing introduction of cases into a new territory. And in this case, we provided not only the code, but we provided an online app so that people could change these key parameters, which in February 2020 were very unknown, i.e. how many people show fever, at what point in their disease course did they start showing fever. And this was really useful to demonstrate that perhaps you needed more than thermal screening. Next slide, please. And finally, the London School transmission model was also used to assess how lockdowns or other non-pharmaceutical interventions could be implemented to maintain the epidemic under a healthcare threshold. So this is just a figure to show that we were asked, what about if there's a 1,000-bed trigger for a new lockdown, 2,000 or 5,000 bed trigger for healthcare utilization? And then you can see the lockdown periods in gray, and then the projected epidemic trajectory by the different colors of lines. And you can really see there the uncertainty. So we don't need to look too closely at it, but this is a kind of an example of the kind of questions we were being asked. Next slide, please. So these are just some examples, but there's many others. And the key thing is that transmission models can be used for a whole range of purposes. And when you are both making them and assessing and interpreting them, it's important to remember what the model is trying to do. And the purpose impacts the methods that we as modelers choose and the amount of complexity that we put into it. And throughout the epidemic so far, as always with epidemiology, you need to have a keen understanding of your data streams, the weaknesses, the limitations. You need to keep an open mind and update your results as the situation changes. And also you need to quantify and convey your uncertainty in your parameters and in your findings. Next slide, please. This is the Center for Mathematical Modeling at London School. We provide open code, open access, and we try and have a fair and equitable collaborative working, and all of our work is online in our repository. So thank you.
Thanks very much indeed, Ros. Incredibly helpful romp through all the things that modelers have been doing over the last year or so, and obviously a very important part of the response. So finally, I have great pleasure in introducing Kirsty Irvin. So Kirsty is listed in your program as patient representative, but Kirsty is a lot more than that. And one of the very important roles she has, and challenging roles, I'm sure, is to chair NHS Digital's independent group advising on the release of data, which has met incredibly frequently throughout the course of the pandemic, and has helped NHS Digital and encouraged it to enable access to a large range of data sets to support our research efforts. So Kirsty, you're going to talk to us about, is there room for patient perspective in a pandemic? Over to you, and many thanks.
Thanks very much, Kathy. And if I could have my slides up, please. So thanks for the introduction. As Kathy said, I'm Kirsty Irvin. I'm chair of IGARD. Very pleased to be here today. As one of my colleagues pointed out when he very kindly had a look at my slides, he said there is of course no one patient perspective, and so today I'm not presuming to speak to all patients, but I thought it might be a useful insight to see what's been going on, at least at NHS Digital. So if we could move on to the next slide, please. So first, a little bit about IGARD. We're independent, we're not employees of NHS Digital. We've been reviewing applications for health data since our formation in 2017. What was new about IGARD compared to previous review bodies was that IGARD incorporated the patient voice and fully independent membership. And noting the composition of a great number of the audience today, I should mention that IGARD also has researcher representation, and we're recruiting for new members shortly. So IGARD has a wide remit over applications for data from NHS Digital. For example, applications for GP data for pandemic response and any patient level data request, including pseudonymized data. So it's not just identifying data, we also have remit for over applications for pseudonymized data. As well as chair, I'm a patient representative. I have 2 children with rare genetic and other conditions, and becoming more involved in representing the patient voice is what first prompted me to apply for the lay role on IGARD. So the links I've put up here are links to our detailed minutes of our recommendations, and some of those recommendations might be not recommendation to NHS Digital not to release the data, so you can see it in all its gory detail. Sometimes the minutes run to 20 pages. We do aim to be as transparent as possible. And then also I put a link to NHS Digital's register of approved data releases. So these are the applications which are successful, and the data release register, which is undergoing some work at the moment to make it more user-friendly, has a lot of detail about the data that NHS Digital has flowed. So moving on to the next slide. So before the pandemic, we thought we were busy. We met weekly, sort of an 8-hour meeting once a week, and discussed challenging applications. By March 2020, our workload had more than doubled. There was more data, there was more applications, and to put it simply, and it was all on an emergency footing. There was a period where new data sets were being onboarded weekly, compressing a process that used to take many, many months. And it's no exaggeration to say that the staff at NHS Digital were literally working around the clock. The slide should be self-explanatory, but I spotted one acronym there, and that's PAG. And PAG is the Profession Advisory Group, which represents the BMA and RCGP, and we work with them on applications for GP data and pandemic response. So moving on to IGARD's response, which is the next slide. So how did IGARD change? If we just go on to the next slide, that's perfect, thank you so much. In order to ensure that our voice was heard, we had to adapt to the new environment. Sir Martin probably isn't aware that I spent Easter last year reviewing recovery trial consent materials with the NHS Digital DigiTrials manager, but we had to be nimble, responsive, pragmatic. We set up a whole new meeting. So we run 2 meetings a week now. One is catchily named the COVID-19 response meeting. But throughout this time, we still provided challenge and questions because we tried just to keep in mind that we've got a duty to the public to ensure that there was still transparency and rigour, even in the midst of a public health emergency. So in some applications, there was evidence of or robust plans for PPIE. And in those cases, IGARD applauded it. We didn't second guess it. We didn't try and, offer our own, PPIE in those cases. However, in the majority of applications, there've been no PPIE, usually due to understandable timing issues. And in the rare occasion, it did appear that it hadn't occurred to the researchers. But in those cases, we really felt the weight of the challenge. So I'm just going to come now to my final slide because I really want to make sure we've got time for questions. So moving on to the next slide. So the overwhelming experience was that every applicant for data thought that their application was the most urgent for the COVID response measures. Obviously, some really were. I mean, we had that brilliant exposition on the recovery trial, for example. The prioritisation took place before applications came to IGARD, but the pressure was palpable. And we did have to stop sometimes and think, was it the most effective triage and prioritisation that could possibly happen? I could see that there are applications for non-COVID research that were getting stuck as other applications leapfrogged over them. But that's what happens in an emergency pandemic situation when the system was already running at full capacity. While new legal gateways opened up to facilitate sharing, the existing transparency requirements didn't go away. Now, I think there are probably gaps in public awareness that could be patched up now with the overwhelming focus of ensuring that people are informed so that we maintain public trust in the system of sharing health data. Perhaps that's something we might explore in the questions. I also wanted to note there's a public involvement in a pandemic, which is an excellent HRA publication. And it talks about the benefit of having robust PPIE, even in a pandemic, as a route to more ethical research and as a means to improve study recruitment and retention. So I think my final thought that I'd like to end on is that public trust is hard won and easily lost. And if I just, on the very final slide, there's just a contact details of how you can get in touch with the IGARD Secretariat. And I'm sure my Secretariat manager will be delighted that I've shared that there. But thank you very much, Kathy, over to you.
So thank you very much to all of our panelists for a very wide-ranging set of talks. So quite a lot of questions have been coming up in the panel. I've seen them whizzing past. One that's really common to all of you, and it'd be good to have a brief response from all of you, which really extends and builds on the comments that Kirsty was making, is to what extent has the involvement of patients and the public kept pace with the acceleration of data science during the pandemic? So maybe each of you could perhaps comment briefly on that. Firstly, Martin.
Well, very briefly, remember that at the beginning of recovery, essentially there were no patients who had had COVID. So that's the first thing to remember. There were no doctors who treated COVID either. So, you know, that's an unusual situation. But we did, if you like, check of our consent materials and other information with a patient group we had. They obviously were from a different setting and so on, but it was at least something to try and make sure we were writing in plain language. We have subsequently taken a very deliberate transparency agenda. So it's good to hear you talk about that, Kirsty. So that everything I've said, every protocol, every ethics submission, every MHRA submission, every result, how many patients we recruited, how are we training the doctors, all that stuff has always been on the public website. So you can see everything. The only thing that's not there is the results that even I don't know yet. But I think the other thing is, and I saw Georgina McMasters, who's done sterling work with our patient group on NHS DigiTrials, is in parallel involving patients in discussions about the use of data specifically for clinical trials. We've done a lot of that work, even despite, if you like, COVID. We would have done that anyway, but in a sense, COVID and recovery trial has provided a focus. There's now a use case that people can get their arms around and say, we can see how the value of that. You know, could you have done that differently? What are the lessons for future trials? And that's been extremely helpful.
Thanks very much, Martin. And just one reflection is that I think your experience and that of many researchers has been that patients and members of the public are A, really keen to be involved in the conversation and discussion, and B, more than happy and willing to work at pace because, you know, the pace is relevant to them just as it is to the research community. Liz, any comments from you on that?
Yeah, definitely. So Pioneer has what we call a data trust committee, which is a group of patient and public members that review all of our proposed activity. During COVID, they were amazing. They were meeting late at night at really short notice. And for us to support a project requires 80% of their support. If they say no, then the project is a no for us. So as Martin said, we didn't have any patients with experience of COVID. And as a doctor, it was terrifying not having an experience of COVID myself. But we were able to run through all of the proposed projects with that group, and some of the more sensitive things. So for example, looking at ethnicity and outcomes from COVID, we worked with our patients in the admissions unit to talk to them about the data that we were collecting and how we hope to use it. And the support was amazing. You know, this is things that are affecting our communities, our patients, and their support for what we were doing and their willingness to get involved afterwards, review materials, has been just inspiring.
Thanks very much, Liz. And Rosalind, I guess in your world, it's actually quite challenging to have conversations with patients and members of the public because of the sort of technical nature of some of the work that you do. I wonder how you've kind of dealt with that challenge.
No, it's a great point. And I think I would just also echo what Martin raised about transparency. So from the very beginning, with our technical work, with our models, we've always made all of our code, our technical code, available at the point of preprint, not at the point of publication, which allows a bit of a feedback loop, so that it's not everybody that can interpret that, but we really think it's very important to make the code available, to make explicit exactly what we've done, where those assumptions are, and allow that potential for technical as well as general feedback before things get finalized.
Thanks very much. So Kirsty, you really raised this issue very much in your talk. Are there anything else you want to add?
Well, I think probably the only distinction I'd make is that I think consented trials, and particularly Sir Martin's trial is an exemplar, but I think the response to the proposed replacement GP data collection is a sign that the public aren't fully aware of what goes on in terms of health data usage. And I think this is probably a really great opportunity to widen the conversation beyond GP data to the benefits of health data generally.
Yeah, very good point. Thank you very much, Kirsty. So a few other questions, we'll just deal with as many as we can. So one for Martin and Liz as well is how can we extend platforms like Recovery and Pioneer to incorporate primary healthcare?
Well, I think there are two different pieces to that. Was it primary healthcare? Actually, three. Is it patients, wherever they may be? Let's not think of it in organisational sectors of the NHS, which is, that's done for administrative reasons. And is it data? So to give you an example from Recovery about why GP data will be important, we now have 3 treatments that in the acute phase improve your chances of survival. We now have a condition which we didn't even know anything about a year ago called long COVID. And we have no idea whether these treatments that make a big difference to basically how much damage is done to the lungs and therefore to survival in the acute phase might or might not have a big impact on your chances of getting long COVID. Where do you go if you have long COVID in your patient? By and large, you go to your GP to tell them about feeling tired, breathless, miserable, and so on. And so actually there's a lot of good reasons for wanting to be able to do that. Yes, that's consented, but actually the data have to be there and have to be accessible. So one can't go through a sort of UK Biobank merry-go-round of having consent, but not actually being able to get hold of the data. So I think there are really good reasons. In terms of future platforms, I mean, Recovery can easily be, and we hope to extend it through to other viral infections. So the evidence base for how we treat seasonal influenza, which of course places huge winter burden on the NHS and on patients, kills many patients, the evidence base is pretty pathetic. And a trial like Recovery could easily address that. Respiratory syncytial virus, another virus that does much the same thing, likewise. And then let's think about other conditions. Cancer hasn't gone away, common cancers particularly haven't gone away, heart disease hasn't gone away, osteoarthritis hasn't gone away just because we're talking about COVID. And there's so much more we could be doing there.
Thanks, Martin. Really great points. Liz, extension into the primary care setting for Pioneer, and perhaps a supplementary question is, what are the prospects of something like Pioneer becoming a national rather than regional phenomenon?
Yes, so primary care data is hugely important. All our secondary care patients start off in primary care, and understanding who is most at risk and how we can mitigate that risk at the most earliest point and stop them from becoming a secondary care patient would just be amazing, as well as long COVID. So we are working with some primary care practices to bring data in, but Pioneer is expanding rapidly, but also in a manner that is sustainable. So we have our first foray into bringing primary care data in now that we have the ambulance data coming through. For regional versus national, well, Pioneer is really proud to be part of the Society of Acute Medicine, and that represents over 153 hospitals which pull data into a benchmarking audit that takes place. And so we're utilizing those links to have a wider footprint for Pioneer. So although at the moment we are very proud to represent our region and recognizing that Birmingham is hugely diverse and also faces massive challenges with health, we are working with our SAMBA partners to make sure that we have national representation, and we would be delighted for other people to join us. So do get in contact.
Kathy, can I just come back on this primary care issue, and particularly on a point that Liz made, which is
yes, briefly, Martin. Yeah,
everybody in secondary care starts in primary care. Actually, everybody starts in no care at all. And what we have to think about is, how do we turn a national health system into being a national health system, not a national disease system? And that, I think, requires starting with the prevention and early management and early diagnosis. There's a huge amount one could do there. But that requires thinking of the whole rather than some individual segment of the system. Data is one element of that, but if we actually really want to think about patients first, let's think about patients wherever all of us may be. We are all current, past, or future patients in some order, and let's think about that piece rather than thinking simply about where do their data happen to crop up in the system.
Great, thank you very much, Martin. Okay, I've got a brief additional question for Ros, and hopefully we can fit in one for Kirsty as well. Let's see how we go. So, Ros, SPI-M has talked a lot about how carefully they make sure that their results are checked and double checked, or run by different teams, or models are run by different teams to ensure reproducibility and robustness. I just wanted your thoughts on how important that's been, and have there been important discrepancies that you've had to deal with there?
So as far as, that's a great question. As far as running by different teams, it's more that you take different teams' models with different implicit assumptions, different methods, and then bring those together, bring the findings together, and try and understand why you see differences in outcomes, and how much difference there is and how important that is. So that kind of comparison and bringing multiple results together is something that's gone on from the beginning, to try and, it's this question of uncertainty. There's so much uncertainty, and you don't always want to make everybody harmonize onto the same assumptions or the same decisions, because everybody has different scientific interpretations. And so that's that kind of consensus building has been critical. And because the UK has such a depth of experience and talent in infectious disease modelling, it's been possible to have multiple groups informing on the same questions, which adds a lot of strength and to our understanding of what's going on and our capacity to make decisions.
Wonderful, thank you very much. And a quick final question for Kirsty is, how much do you think direct interaction with researchers might be helpful for IGARD and its decision and advisory processes?
I think it may well have a place, but I think, as you know, Kathy, IGARD members are really enthusiastic about the research. So often when it comes down to deliberation, it's not about the validity of the research. Often it's to do with the contractual and the legal system. So, I mean, we're absolutely open to it, but I think overwhelmingly IGARD members, we don't need to be convinced about the benefits of the research. Well, of course, we'd like to see more researchers, but
yeah. Wonderful, that's really helpful. So that's been a super session, and thank you very much to all our panelists and for answering those questions so thoroughly and helpfully and comprehensively. I think we are all now due a break, and do come back for the next session. Thanks again, everybody.